coming in, so we'll start there. So hello again, and welcome to this SPLICE lecture on COOP, or care of the older person. I think this is the first one I'm doing for you guys this year, so hello again. And I appreciate that it's a Friday night, so I won't try and keep you too long. Hopefully this will be a short lecture, give you a bit of guidance as to the key areas to revise, and then also a few sort of OSCE topics to think about as well. I'd like to say thank you and welcome to Dr. David Pepperer, who's kindly helped me out, reviewed the slides, and then has also agreed to help answer any questions. So as always, bang your questions in the chat, and we'll try our best to give some useful answers. So with that, let's start. So fifth year is quite an interesting year in that you have some modules that are super specialist and include topics that you won't have encountered before, and then you've got GP, COOP, which are specialties in themselves because they're so general, if that makes sense. So the plan today is to cover the key topics specifically related to Geries, rather than give you a Gen Med lecture. So that kind of being said, I've got a slide that includes what I think are the key general medicine points to cover, but then the main focus of the lecture is going to be around these 5 areas in the middle, and then a few bits of OSCE stuff as well. Again, the focus here is going to make it be useful for your exams, but then a lot of these topics will be good to bear in mind for when you're working, as you'll all have to do some geriatric medicine at some point, given the aging population. Cool. So, as I was saying, these are the areas I think are most useful to know in terms of COOP. So, heart failure is the big one really for cardiology. It's pretty much any chronic heart condition eventually results in failure of the heart to meet the body's demands. COPD is a big one for respiratory. Knowing stroke, Parkinson's from neurology will stand you in good stead. UTIs, pneumonia are massive topics to know for any year of med school, and then a few kind of joint problems, disorders associated with aging, so osteoarthritis, osteoporosis. I'd recommend reading over those again. And so then this is kind of what a lot of geriatric medicine's been based around in recent times, and it's actually potentially an outdated system. It's more being replaced by the term frailty, which we'll kind of go through in a bit. But the purpose of this is to highlight areas that contribute to the decline in health of an older person. A problem in any of these areas can cause quite a significant reduction in quality of life and their health of these individuals. And then I quite like this slide as something to think about for when you're in an OSCE or in real life taking a history and making a management plan. Because COOP is a bit more than just the physical complaint, more than this top circle. If you consider all these areas, then you'll be a brilliant doctor. So yes, tackle the physical complaint, but also think about their home environment. Do they have the correct support? Are they safe at home? Can they get themselves to the shop to buy their food? How's their mental health? How are they feeling? So particularly during COVID, loads of people, not just the elderly, became very isolated. And that can have a big impact on their mental health. So it might be nice to add that into your OSCE spiel, something about COVID, mental health. And then, do they need any social support? Are they coping with cooking, cleaning, washing, dressing? What are their care needs? And then perhaps more of an occupational therapy point, but how is their external environment? Are they safe at home? Can they get to the shops to buy their food? Do they need a walking aid, etc.? So just the wider, more holistic things to think about, not just the core medical conditions. So let's do an SBA. Okay. Lovely stuff. So this is a classic style of question assessing your knowledge of falls investigations, really. So there may be a role for all these investigations, but we're looking for the initial and the most important. So the vignette talks about symptoms being worse on getting up, and this is kind of clarified as being worse on getting out of bed. The symptoms are worse when they go from lying to standing. And in addition, she's not hit her head, and there's no change in symptoms on head movement. So this rules out the need for A and then also B. A pelvic X-ray might be useful, but there's no mention of pain, and then of hip pain. And then the ECG might be useful if you're suspecting cardiac syncope. But given the drug history of a diuretic and then an antihypertensive, a lying standing blood pressure is a very important initial investigation. It's just a very important investigation in any elderly person, really, but particularly somebody presenting with falls. Cool. So the second SBA. Okay, so this is a bit of a trickier question, and this was kind of designed to test you a bit. So this is to assess your knowledge of the consequences of falls and what can happen. So our patient's been found on the floor, suggesting that they've had a fall, and they haven't been seen for 2 days, which kind of further suggests this might have been a long fall. Then if we look at the blood results, so there's a mild anemia, but nothing too concerning, and then a normal white cell count, which effectively rules out an infection here. Then the CK, so this is at the higher end of normal, but for rhabdo, you'd expect this to be in the thousands. You'd expect it to be way up. And then some other features that might be present in rhabdo are sort of dark brown, smoky urine, and you can get quite severe acidosis on a blood gas, which in fairness wasn't given, but they were the kind of features you'd be expected to see. Then the sodium levels quite high, as are the urea and the creatinine levels. So this is suggestive of an AKI. Renal stone might have caused an AKI, but it would have to be pretty severe to raise the sodium. So therefore, the most likely answer here is just dehydration. This patient's been lying on the floor. They've not been taking any water, so therefore the kidneys have gone into an AKI due to hypoperfusion. And then because there's less water in the blood, there's relatively more sodium. So you get this hypovolemic hypernatremia. So then also, if this kind of question was trying to get at SIDH, they'd be more likely to give you urine and plasma osmolarities to properly work it out. And then other things to think about are you're stopping any nephrotoxic drugs at this point, so your diuretics, your NSAIDs, etc. Okay, another SBA. Very nice. Yeah, so this is just a bit of revision from ortho from last year. So what we've got here is an immobile elderly patient who's got an intracapsular neck of femur fracture, and there's a risk of complications. So they've opted for treatment here, and then the correct treatment therefore would be a hemiarthroplasty. To run through the others again, your cancella screws are used in younger patients to preserve the original femoral head. Then the DHS used in intratrochanteric fractures, so a bit lower down. Intermedullary nail used in the subtrochanteric and then femoral shaft fractures. And then your total hip arthroplasty is used in your more mobile, slightly younger elderly patients. So this patient basically won't be able to handle the physiologic insult of major surgery like a total hip replacement. And then another thing to be aware of that Dr. Pepper mentioned to me actually was that severe cognitive impairment is a contraindication to a total hip replacement. And this is because you need to have a good understanding of the pre and post-op instructions. So things like you can't cross your legs or you can't sit in certain positions because it might dislocate or fracture the implant, which can then be really, really difficult to manage. So if they can't understand that, then they'll get a simpler hemiarthroplasty. Right. Okay, so this section is about considering falls, and falls are a massive topic. Such a common presentation to A&E. Something like 50% of over 80s will have at least one fall per year. So before we kind of go through some revision slides, I want to talk through your falls history, as it's just a very, very OSCE topic. So your basic structure of your history of presenting complaint is these sort of top three boxes. And it's quite similar to your epilepsy, syncope histories. So asking about before the fall, what were you doing? Were you standing up? Were you moving your head? Were you walking to the shop? Did you feel funny or lightheaded? Might suggest a vasovagal. Had they been recently unwell? That might cause dehydration or post-viral complications. Any other recent symptoms that might be related to an overarching condition. Any memory loss of the events before the fall. Then during the fall, so this is the fall itself. Did they trip? Did they just collapse? Did they hit their head or their hip or their knee or their elbow? So any other associated injuries? How long were they on the floor for? Because they could have further complications like dehydration or rhabdo. Did anyone see? As a collateral history could be very valuable. And then any other symptoms during the fall, like did they lose consciousness? Then afterwards, how did they feel? Any change in cognition, any focal neurology that might indicate a stroke? And a crucial question is whether this has happened before, as there might be an underlying condition that's causing these falls. Then following your usual structure, past medical history, drug history, social history, etc. But these are some key points to think about. So your past medical history is trying to work out what their medical baseline is like. So any vascular conditions that might suggest a stroke, any seizure conditions like epilepsy, cardiac problems, arrhythmias that might cause the cardiac-related fall. Drug history is really, really important, as this could be a consequence of medications. So too many antihypertensives causing somebody to become hypotensive. Any drugs could be quite sedating, so antipsychotics or benzodiazepines might have caused somebody to fall or trip up. And then blood thinners are always something to ask about in the elderly, because this could be catastrophic if they've hit their head and they're bleeding. And then social history, again, another really important aspect, because what you're trying to establish here is what's the functional baseline of this person. And that's really important because you need to know what they used to be able to do, how they could take care of themselves so that you can get them back to their baseline. Because once they're in hospital, if they've been unwell, they're going to stray from that baseline. But you need to know when they're back to what's normal for them to be able to discharge them. And that baseline can fluctuate dramatically between somebody who's going back to a care home and needs full-time support versus somebody who's completely independent and can go home. But you need to know what that is. And that's why social history is so important. And then this is kind of just a list of some causes. It's not an extensive list. But these are some of your differentials you might be thinking about when you're taking your history. So could this be neurogenic, like a stroke or a seizure? Could it be due to a visual impairment? They couldn't see and they tripped. Or did they trip because they can't feel their toes as they've got a peripheral neuropathy? Could this be cardiac related? They had a heart attack and fallen. So they have an arrhythmia and their heart briefly stopped. They had a PE, or was their blood pressure too low? Then some other causes. So infections can cause havoc. UTIs are really common. Sugar levels, both high and low, can cause falls. Medications, again, as we touched on, a big one to think about. And then you've got your differentials, and you've taken your history, and what are you going to do? So this is more of a revision slide to look at a bit in your own time. But some areas you might want to think about. These are some kind of investigations to consider that might help you find an underlying cause. The big one here is that pretty much everyone will get a urine MCNS, as it's better than just a urine dip for the elderly and for picking up UTIs, because they're just so common in that population. Then, of course, you want to treat the underlying cause, but the emphasis then becomes on preventing a future fall. And for this, you're going to need the whole team to be involved. So strength and balance programs with the physios, occupational therapists assessing their home environment, the GP reviewing their medications for those that can be stopped or unnecessary. And then this last one's kind of a list of other areas you might want to consider in your management plans. So things like assessing somebody's vision or going through their osteoporosis risk factors, but something to do perhaps more in the GP setting. Then consequences of falls. So this is the last little section on falls. There can be catastrophic consequences of falling on an individual. This can be a physical ailment, so this could be a fracture or a bleed on the brain, which are obviously very nasty. Dehydration, rhabdo infections, the consequences of lying on the floor for a while. Another one is sort of they can get bad burns if they fell against a radiator that's been on and they can't move. But then also there can be these invisible and potentially more damaging mental and social problems. So a loss of confidence in walking, or their previous lifestyle, they've got no confidence in what they used to be able to do. It can cause a profound decrease in quality of life. And this can really affect someone's health. And not leaving the house or moving around leads to immobility, isolation, which can kind of culminate in depression and other medical issues. So if they're not moving around, they might get DVTs or the stasis of bodily fluids, so infections. And in general, it's just quite a sad thought. And then perhaps most importantly is there's a massive correlation between falls and death. So if we can try and prevent them going back through the MDT approach, then that would be the ideal situation. But these are just some things to think about as well in your more holistic review. So moving on, let's do an SPA. Okay, cool. So the majority going for the right answer, and I'll just run through this now because this is another kind of common style of question, and it's testing your knowledge of CT head guidelines. So in this SPA, we've got an 84-year-old lady who's hit her head. She's not vomited and otherwise is completely fine, but the guidelines state that because of her age, she needs a CT head within 8 hours just to make sure that she hasn't had a bleed. So these are your guidelines, and these are worth going over close to the exam just because they can come up and aren't too difficult to learn kind of the rough sort of ideas around it. So for instance, the criteria for a CT head within 1 hour are all quite big issues. So seizures, skull fractures, genuine neurology, vomiting, changes in GCS. So these big things to think about. If they kind of come up in a question and you're thinking, well, something serious is going on, we need to get an urgent CT head. Then the criteria for 8 hours I found a lot harder to remember because they're just a little bit more vague. But the key ones to think about are those with bleeding, clotting disorders, or are on anticoagulation, but also those over 65. And the reason for this is that as you age, the brain atrophies, so it decreases in size. And that stretches some of the blood vessels that bridge between the meningeal layers, and particularly these sort of fragile bridging veins that are between the arachnoid and the dura mater. And it really doesn't take much force to sever one of these veins, and they can slowly bleed, causing a chronic subdural. So that's why the answer is CT head within 8 hours, purely because the only criteria she meets is being over 65. So another quick snapshot SPA. Yeah, lovely. Just a quick one. CT heads, very common, very easy to put a question on because they just need a picture. But this is your chronic subdural that I was talking about. If you're thinking about the difference between a chronic and an acute on chronic subdural, an acute subdural is going to appear white, quite bright, this crescent shape, and that's because of the hemoglobin in the blood that shows up. So the iron in the blood will show up as white, and then as that over time that hemoglobin kind of breaks down, it becomes darker and darker until you get this sort of dark black shadow in a chronic subdural as all the hemoglobin's gone. So in your acute on chronic, you will get these kind of two separations of an area of dark and then an area of kind of bright white. Yeah. Let's do another SPA. Okay, very good. So I thought this would be quite a difficult one, but I've thrown this in because I've seen this a few times over various places. And this is just a diagnosis to bear in mind. So this is carbon monoxide poisoning. It doesn't happen as much anymore because there's new technologies and carbon monoxide alarms and stuff like that. But it doesn't mean that it might not come up. So basically, this elderly man in question hasn't left his house. He's been isolating for the last 2 weeks. And then he's developed these symptoms of confusion, associated headache, and then a bit of a visual change. And these are quite classic presentations of carbon monoxide poisoning. And then the investigation you need to diagnose that is your carboxy hemoglobin levels. So another question on confusion. Again, very nice. So the answer to this one is E. And so continuing with that theme of confusion, got an elderly guy admitted due to confusion, and then the source is supposedly found and correctly treated, yet he's still confused, still has this reduced AMTS, his speech is still off. And so this is suggestive of ongoing delirium. So therefore, the next best step is to reinvestigate and try and find the cause of this continual delirium, because it's quite likely we'd have missed something when we've just gone for our UTI treatment. Just a point on antipsychotics and benzodiazepines. They should be used very cautiously in elderly care due to a risk of sedation and falls again. And then, yeah, I mean, liaison psychs are a bit unnecessary as it's not a psychiatric complaint. Security is a bit over the top, and it might be best to try and de-escalate the situation first and try and calm the patient down if they're a bit aggressive or agitated. But in this situation, we need to find the cause. So let's do another SPA. Yeah, cool. So this is another kind of classic medical question because it's another easy picture that they can put in. So again, we've got a delirious patient in this kind of drowsy state, unable to give a history very well. So there seems to be some abdominal pain. They've done an abdo X-ray, and which is showing constipation. So this kind of smoky grayness throughout is fecal matter. And then the darker area on the right-hand side, this picture, but on the patient's left-hand side, is impacted fecal matter. So the PR needs to be done to confirm, and then using laxatives, so oral macrogol in this case. One more question, then we'll go through a bit of delirium. Yeah, very nice. I always used to hate these questions where it's lots of very similar answers, but you've done very well there. Confusion screen is a really common set of investigations that you'll undoubtedly have to order at some point in your careers. So it's good to know a bit about. Just through a couple of the other answers: cortisol, amylase, urate, group and save not typically used. So hence B is your correct answer. So what makes up your confusion screen? So this is kind of just to demonstrate some of the investigations that you might consider, and then the blood tests that you're likely to order. So get your observations at baseline, do a mental state analysis, and then the urine MCNS, like we said, looking for infection. Things to consider: sputum culture, if you're worried about pneumonia, same for a chest X-ray. ECG is always useful. Blood cultures again for infection, and your blood gases. other things maybe to consider: CT head if there's some neurology, or PR if you're considering constipation, and then your blood tests and just the reasons for it. So full blood count can show you your anemia or your infective markers. Electrolyte disturbances can cause changes in cognition, confusion, infection, inflammation. Again, all things that can cause confusion. Liver failure or impairment. You can get high levels of nitrogenous products, which can cause encephalopathy, that sort of thing. High and low calcium deficiencies in some of your minerals that make up the blood cells, and then glucose is a massive one, always to think about. And then kind of another revision slide, but sort of just to go through a little bit. What is delirium? It defines this state of mental confusion that starts suddenly. It's acute, but then it's only temporary, so it's reversible. Then some common causes I'll put on here in a bit of a mnemonic that I use. But the common ones or key ones to think about, I think, really are constipation, infection, and pain, because these can kind of go unnoticed to the outside. And if someone's confused in a delirious state, they won't be able to tell you that they're in pain, or they won't be able to tell you that they've not gone to the toilet for a week. And in terms of how delirium presents, you've kind of got these two poles that they might present with. They can have this hypoactive, where they're withdrawn, uncommunicative, low mood. They don't really move anywhere, which kind of in extreme cases is this catatonia, stuck in one position. Or they can be the opposite end of the spectrum, be really hyperactive, very agitated, aggressive. They can have hallucinations, altered sleep patterns, which can kind of worsen the delirium because then they become even more sleep deprived. And then treatment is essentially treat the underlying cause, but some areas to look at in terms of prevention. So things like maintaining familiarity, having the same nurses looking after them, pictures of family around, turning the lights off during the night, on during the day, keeping the ward quiet to let people sleep properly, and then making sure they eat, drink, have appropriate pain relief. And then in terms of diagnosing delirium, a few methods to think about and some things that might come up in an OSCE in some capacity. So there's these two tests here. So the 4A's test and then the CAM score. So the 4A's are your alertness. AMT4 is a sort of shortened version of AMTS, just incorporates age, date of birth, place, so where they are now, and then the current year. And then there's an attention assessment, and then if there's been an acute change, the attention assessment might be something like count backwards from 20, or can you name 7 months? So normal 0. If they start it, can't complete it, they get 1. If there's no way you can assess it, then that's 2 points. And a score of 4 or more means that it's highly likely the patient has delirium or a cognitive impairment. Then the CAM score is another good method for diagnosing. So they need to have both an acute onset fluctuating course and have this inattention, and then either disorganized thinking or altered levels of consciousness. So if you have both 1 and 2 present and then 3 or 4 present, then that's a diagnosis of delirium. And then the AMTS, the abbreviated mental test score, is another good thing to learn or to know. There's kind of these 10 areas, and it's usually written in a performer somewhere, but it's good to know, probably for the OSCE. Just to clarify, there's 10 areas, but the 11th section there is just as a reminder to get them to recall the address that you gave to them earlier on. So something to go through. Then a bit on dementia, and I'll include this in here because it's a massive topic. What it is a syndrome. It's a combination of symptoms that result due to a decline in the function of the brain. And Alzheimer's is your most common. It's very well reported. Vascular dementia with Lewy bodies, are also reasonably common, but there are also some rarer causes. The ultimate aim of your investigations is to try and rule out any condition that might give a dementia type picture that isn't actually dementia, because the only real way to diagnose the exact cause of dementia is a post-mortem, to look for things like your tau proteins or your beta amyloid if it was Alzheimer's. So if you can rule out an organic cause, then that's always useful. Then in terms of your management, there's lots of conservative measures to consider when making your management plans. taking a team-based approach, getting social services involved, sorting out packages of care, etc. Reduce the risk of falls and things like that, or accidents by leaving the hob on. Using Dosset boxes so they can remember which medications to take and when is really good and useful for kind of comorbidity management. And then controlling risk factors, so your blood pressure, anticoagulation, smoking, to stop things like strokes or vascular dementia that might make your dementia worse. There's also some medical management options. And the main aim for these first two classes, the acetylcholinesterase inhibitors and the NMDA receptors, is to replace or boost the neurotransmitter levels that can often be quite low in dementias. So by preventing the breakdown of acetylcholine, then they'll be more about for longer, which theoretically slows the progression of Alzheimer's. Then there are some downsides to be aware of. Acetylcholine activates muscarinic receptors. So if you remember your physiology, the impact of this is that it can cause excitation in certain muscles, such as the detrusor in the bladder, and therefore could have the unfortunate side effect of incontinence. And then, yeah, cool. Let's do an SPA here.
Coops, you've muted.
Hi. Sorry, yeah.
Chris, you're muted. Cooper. Chris, you've muted yourself and I can't unmute you.
Sorry, I didn't realise I was muted. So just to go back through that, so the answer here is dementia with Lewy bodies, which you all did very well. The key point I wanted to make with that is with Lewy body dementia, what happens is you get the dementia first and then you get the signs of Parkinsonism, or it can present at the same time. But with Parkinson's disease, with dementia, you get the Parkinsonism first, and then later down the line, you get dementia. And that's the key differentiator between the two. A few of the others, so pseudo-dementia or depression can mimic dementia, but then the case or vignette might suggest that there had been a loss of a partner or a friend or other depression-type symptoms. They might answer things like, I don't know, to a memory question rather than just getting it wrong like an Alzheimer's patient would. And then, yeah, there would also be, with Alzheimer's, very common, it'd be a continual course rather than this fluctuating course in delirium. So this is just a little flow chart to kind of help you work through your differentials. So starting at the top, has the decline in cognition been acute? So has it happened recently? If the answer is yes, then it's probably unlikely to be dementia, more likely to be a delirium or something else, because dementia tends to be a longer term cognition decline. Then is there signs of behaviour change, which occurs in conditions like frontotemporal dementia? If you add incontinence to this, then you might suspect normal pressure hydrocephalus, which has the triad of sort of wet, weird and wobbly, so incontinence, behaviour change, and then falls. CJD, Creutzfeldt-Jakob, is a rare differential, but does come up. So if you've got somebody with dementia, behaviour change, and then involuntary muscle contractions, then maybe consider that. Then the other side is kind of your more common dementias. So vascular paths and a stepwise decline points towards vascular due to lots of little strokes, and then Lewy body dementia, you get these kind of Parkinson signs and hallucinations. This is another revision slide if you're still stuck between the difference between delirium and dementia, and kind of the key differences between the two. I found this a bit useful, so if this is something that will help, have a little look through afterwards. We've put the slides up, but I'll move on from this. So an SPA here. Okay, very nice. I thought this would be a tougher question, a little bit of a harsh one, but majority of you have done well here. So this is kind of just some side effects of medications and some common medications that elderly patients might be on, and it can be useful just to know a few side effects. So donepezil is one of the key side effects is cardiac arrhythmias, which could present incomplete heart block. The others, amlodipine, your swollen ankles, tachycardia, palpitations are your most common ones. Omeprazole, always good to be aware that PPIs can cause a hyponatremia. Danzatron is common antiemetic use, particularly in palliative care and cancer patients, can cause a long QT syndrome. And then ropinirole is one of your dopamine receptor agonists. This might be another kind of question if they were to flip this. And they present with behavior change. They can start gambling or become hypersexual or things like that, and then also dizziness and drowsiness. So it's good just to know a few side effects of the more common medications. Apologies, this is just a bit of a word dump. Basically, polypharmacy was banged on about when I did my COOP placement. They all went on about it. The definition kind of changes a lot, but is around 5 to 10 regular medications. The main reason it's brought up is that lots of medications have side effects, and it's very easy to just keep adding new medications on, which are just prescribed to treat the side effects of other medications. So you kind of end up with this cascade of prescription. And then, so also elderly patients are more susceptible to adverse drug reactions. Reasons for this are due to kind of a reduction in their pharmacokinetics, renal function, liver function is reduced, so it becomes hard to break down medications. So it's just good to be aware of this. So for instance, in an OSCE station, there might be a medication review, and you've got to kind of go through it and work out which ones you're likely to stop, which ones are unnecessary, any interactions, just things to think about. Okay, another SBA. We're nearly through here. Yeah, very nice. So correct answer, as most of you said, is functional incontinence. So this question is just to test the different types of incontinence. So the lady here has a serious mobility impairment due to a severe osteoarthritis. On top of this, she's taking heavy pain relief in the opioids, which might make her drowsy, and again, not able to move. So in summary, she basically is unable to get up and go to the toilet, which makes this a functional issue. Another SBA. Yeah, again, lovely stuff. This is stress incontinence. The bladder leaks under the stress of the raised intra-abdominal pressure from the cough. And then first line management is either to lose weight if they're overweight, or pelvic floor exercises if they're female. The other answers are treatments for urge incontinence or further down the treatment pathway. So just a slide on incontinence, because it's a big issue with increasing age. Predominantly a urological topic, but it's so common I thought it was worth covering. You've got your two main types, so your urge incontinence and your stress incontinence. Urge incontinence occurs due to this overactivity of the bladder wall, and this happens due to irritation in situations like infection, but also medications can do it as well, so diuretics, for instance. And management can be hard, so you've got your fluid restriction or this kind of bladder retraining tends to be your first line. But then also there are some medications. So for instance, oxybutylene and tolterodine are your first line usually. So they're antimuscarinic, they prevent the bladder from contracting. But however, they block the action of acetylcholine. So going back to our dementia point, they can increase this acetylcholine burden, anticholinergic burden, which can worsen and speed up dementia. So they're largely avoided in the elderly. So mirabegron is kind of the one that you could use in elderly care as a second line. And then stress incontinence occurs due to weakness of the sphincters. It was sometimes referred to as a kind of sneeze and leak incontinence. So stress like the sneeze causing the leakage of urine. And then first line management is pelvic floor exercises or losing weight. And then duloxetine is a second line, and there are a variety of surgical options as well. And then a couple of other causes to be aware of. So functional, as we went through earlier, not really a bladder issue, but more kind of the inability to reach the toilet. And then overflow, which, as the name suggests, is just an overflowing bladder. So conditions like BPH or renal stones can cause this. Okay, I think this is the second last SBA. Okay, yeah, actually very nice. The majority did get it right. It's a bit of a mean question because it's basically your knowledge of the Rockwood model of frailty, and I didn't really know this that well, but it's something that UCL particularly seemed to like. So I just thought it'd be useful to go through. And so this is kind of the score. It goes from 1 to 9, from very fit to terminally ill. And it's basically a measure of their baseline function that we were talking about. So in the case, for instance, this person was moderately frail, so they needed help with some outside activities and keeping the house. Did have problems with stairs, but then needed minimal help with kind of dressing. Take that up a step to someone who's severely frail and they're completely dependent for personal care. but they seem stable and they're not at high risk of dying. Very severely frail is somebody who's really just approaching the end of life. And then frailty, it's a tough topic to be questioned on, but it's an important topic to be aware of. It's defined as this reduction in the physiological reserve of an individual. What that means is, so in a normal, healthy young person, an illness might knock them slightly, but they've got a significant reserve to be able to overcome that quickly. If you've got no reserve, then, and the older and frailer you get, the harder it is to overcome simple minor illnesses. And then these are kind of the two models, so the Rockwood model and the Prisma score are just good things to be aware of as ways of assessing frailty. Again, they're sort of things you could probably look up rather than learning, but just good to be aware of. And then management, again, comes down to your MDT, essentially, and being well-rounded. Okay, so last SBA. Yeah, very nice. It's another topic you don't need to know in depth, but good to just have a brief understanding of is pressure sores. This picture, as you said, is grade 2, as it's broken. The pressure sore is broken through the skin, but there's no necrosis or significant damage to the structures underneath. This is just a few pictures just to have a rough idea. So one's just your discoloration, bruising of the skin. 2, bit of damage to the superficial layers. 3, deeper damage, a bit of necrosis, and then 4 gets all the way down to the bone and the deeper lying structures. And then these are just some steps that some teams might take to prevent the sores. So repositioning, special mattresses that shift the pressure points every few hours are frequently used now. Things like minimizing skin moisture, so changing sheets quickly if someone becomes incontinent, things like that are very useful. So just wanted to discuss a few topics in the way of care of the elderly that might come up. We covered a falls history. End-of-life care comes up regularly in terms of advanced decisions and kind of the ethics and law around that. I'm doing the palliative care talk as well, so if there's any topics you'd like to cover in that, put that in the feedback and I can make sure that we go through that. Parkinson's exam, good to know. DOLS, also quite useful to know. I'll put a link in the slide in a bit, which has a good coverage of that. Medication reviews, which we talked through a bit, but that's very common. And then just these two at the bottom, which I'll go through quickly now because they might come up, and I don't really remember any teaching on these in terms of writing a death certificate and then confirming a death. So confirming a death, another potential OSCE station that could come up, and something you'll have to do as foundation doctors anyway, so it's good to review. The first thing you need to do is to make sure you've got the right patient and then check their resuscitation status, because there might be a situation where CPR should be initiated instead. Then always useful to read a little bit about the patient if you don't know them already. And then finally, if they're friends or family, about be a nice person, introduce yourself, offer condolences, etc. Then in terms of actually how to confirm the death, wash your hands, confirm the identity of the patient on the wristband, do a bit of a general inspection as you would in most exams, looking for signs of life, movement, any respiratory effort. Then assess for a verbal response by introducing yourself. Check using a painful stimuli, so a trap squeeze or a bit of supraorbital pressure. Then check for the pupillary reflexes using a torch. So when someone died, the pupils become fixed and dilated. Then palpate the carotid artery or a central pulse. There shouldn't be a pulse. Then kind of the crux of it is you need to listen to the heart sounds and listen for any breath sounds. So you do that for 2 minutes for the heart sounds and 3 minutes for the breath sounds. 5 minutes is considered a reasonable amount of time. Probably in the OSCE, you'd say you would do that rather than actually stand there for 5 minutes. And then at this point, the death can be confirmed. So leave the person in a respectful state, put a sheet over, close their eyes, and then then go and document your assessment. In terms of the documentation, this is just going to be all the steps that you've done, and then the time of death, then sign, name, date, number, etc. All the things you would do in normal documentation. And then you would need to go and inform the right people, so the nursing staff, next of kin if they're not already present, and then you'll need a porter to take the body off to the morgue. Then in terms of writing a death certificate, this is just an example from Geeky Medics of one you might need to fill in. It's quite simple, but is worth just working through. So you've got all the demographics at the top, so the name, the place, where it says day of, this is the 5th day of June or the 11th day of June, rather than writing this is Friday of June or whatever. And then it's this box, the kind of the cause of death. So the first line is your immediate cause of death, and you have to be as specific as possible. So for instance, in Geeky Medics, they give the example that writing adenocarcinoma of the right main bronchus is better than just writing lung cancer. Other things to avoid in this point is writing failures, so heart failure or liver failure. And then you kind of got these 3 lines, so A, B, C, and it's basically a chain you kind of work your way back through. So for instance, if you take the example of COVID, line C would be COVID-19 causing B, a community-acquired pneumonia causing, so C would be COVID causing B, community-acquired pneumonia causing A, acute respiratory distress syndrome, and that would be your 3 levels, which would be the ultimate cause of death. And then in box 2, any significant comorbidities, part 2, any significant comorbidities that might not have caused the immediate death, but would have contributed it. So, or contributed to the decline in health. So something like diabetes. And then just fill in the rest of the form. Residence is the hospital rather than your home address or anything like that. And then same things, making sure all the correct documentation things are there. So your name, your grade, sign, date. But yeah, that's the end of the talk. These are some resources that I found quite useful. Like I said, don't neglect your general medicine for 5th year, but focus that on the key conditions, the key common conditions. You don't really need to go anything too niche like you would have done in 4th year. I don't know if anybody else has anything to add, but here is a link to the feedback, and if one of the guys could put that in the chat, that would be great. And then, yeah, thank you very much for watching. As always, if you've got any questions, feel free to message me. Anything you're stuck on 5th year, 4th year, Gen Med, that sort of thing, or anything related to applications to 6th year or anything like that. But thank you for watching, and enjoy the rest of your Friday evening. Thank you again to Dr. Pepper for joining as well. I understand he's been very helpful in the chat, so that's good.
Chris Cooper. Wow. Okay then.